So today we'll be talking about the ketogenic diet in CDKL5 and uh, other epilepsies. As I mentioned, our guest speaker is Miss Erica Tsang. Erica Tsang is a senior ketogenic dietitian and a PhD candidate at the Children's Hospital in Westmead. She has worked at internationally renowned centers in Australia and UK, including the Evelina London Children's Hospital and University College London Hospital. Erica's research interests include the novel field of nutritional epigenomics, or using diet to influence epigenome to improve patients' outcome in rare disorders. Her PhD research uses multi-omic and microbiome sequencing technologies to explore the effects of ketogenic diet in pediatric epilepsy, with the aim to identify mechanisms of action in the diet responders. She has many CDKL5 patients that she sees, and we're very grateful to Erica to present what her observations in keto diet for CDKL5 patients and other uh, epileptic encephalopathies are. So also really quick, this webinar today is hosted by CDKL5 South Asia, and the technology sponsor is IndoUSrare. IndoUSrare, everybody knows like about CDKL5, like that was our the primary disorder which is in the focus of this webinar. So CDKL5 South Asia is a organization that's focused on research and awareness for CDKL5 disorder in the South Asian region. And our technology sponsor is IndoUSrare. Today, the best medical care of rare genetic disorders in the world is in US. IndoUSrare is an NGO working to bridge this gap and accelerate therapies for rare diseases in India. So we're grateful to IndoUSrare as well. And quick agenda, we started with the introductions to CDKL5 South Asia in Indo-USrare. Dr. Erica Tsang will present her presentation and talk about this ketogenic diet in CDKL5 disorder. And then we'll talk about the Indo-US Bridging Rare Summit 2024, followed by Q&A. The Q&A session will be when, like, if there are any questions or you need something from Ms. Erica to elaborate, then that would be a perfect opportunity. So we encourage everybody to put in their questions in the chat, and then towards the end, we'll discuss these questions. With that, I'll request Ms. Erica to please take over and get started with the presentation.
Great. Thanks, Janu. I'll just share my screen. Can everyone see that all right? Just one slide? One screen? Fab. Excellent. All right. Well, thanks, Janu, and thanks for inviting me to speak today for the CDKL5 South Asia community. As Janu mentioned, I do manage quite a few patients with CDKL5 in Sydney, Australia. And this condition seems to have increased responsiveness to the ketogenic diet. So today I'll be going through different types of the diet, different levels of efficacy, looking at some studies recently in the last 10 years, before summarizing with some key points at the end. Right, so before I begin, I'd like to preface and say that the ketogenic diet is a medically monitored diet. And it's important that if this ends up being a therapy that you or your child pursue, it's important to do this under an experienced team of specialist dietitians, neurologists, as well as clinical nurse consultants as well. Great. So as Janu mentioned, I'm from Sydney, Australia. So here we are on the east coast of Australia. We're known for obviously our Sydney Harbour Bridge and our Sydney Opera House as well. And here in Western Sydney, tucked away over there, we have the Westmead Health Precinct and Innovation Centre. So here I work as a senior ketogenic dietitian at one of the largest ketogenic centres in Australia. And here we manage a large cohort of children from about 17 referring neurologists for epilepsy and other metabolic conditions. So first off, what is the ketogenic diet? So we know that the ketogenic diet is a medically supervised diet used in the treatment for refractory epilepsy and other neurological disorders. It's a very high-fat, low-carbohydrate, but adequate protein diet that aims to maintain a chronic state of ketosis whilst providing adequate calories and protein to maintain normal growth. As we can see from our metabolic cycles here, carbohydrate and fat can be used as an energy source in the body, but by actually restricting the amount of carbohydrate we eat and encouraging fat, it actually shifts the energy source from the body from carbohydrates to fats or glucose to ketone bodies. And essentially, the ketogenic diet simulates the metabolism of the fasting individual. So some of you may have known, but we've recently celebrated 100 years of the ketogenic diet. And actually, the origins of the diet can be dated back even before then to Hippocrates' era, where they had first documented fasting as a therapy for patients with epilepsy. I guess in terms of the modern uses of the diet, it was sort of founded in the 1920s at Harvard University with Cobb and Lennox. And they found that seizures for patients with epilepsy improved after 2 to 3 days of starvation. Now, around 1921, Dr. Wilder at the Mayo Clinic found an alternative way to help with seizures that didn't involve starvation. And he found that when we restricted carbohydrates and encouraged fat, we had a ketone-producing or ketogenic diet that also helped to reduce seizures. Now, in 1940 to 1980, the ketogenic diet really was in the spotlight as a key therapy for epilepsy. In fact, it'd be really hard to find an epilepsy textbook that didn't mention the ketogenic diet during that time. However, around sort of the 1970s, with the increased popularity, or I guess the advent of medications such as sodium valproate, the diet actually fell to the wayside. And I guess potentially due to the restrictiveness of the classical diet, which we'll talk about a bit later, we had the progression through several other less restrictive diets that are sort of more commonly used today. So in the 1970s, in Chicago, the medium chain triglyceride diet was founded as a way to provide different types of fat to produce ketone bodies. And I guess more commonly, people would know that Kossoff and the team at Johns Hopkins founded the modified Atkins diet in 2003, where again, we're looking towards less restriction compared to the classical diet, both in terms of calories and protein intake as well. And so I guess looking over the last 80 years of the diet, it really wasn't until the early 2000s with the Dateline special, which many of you may have heard of, for Charlie, or Charlie Abrams, a 2-year-old boy who became seizure-free on the ketogenic diet. It wasn't until that Dateline special was published or aired on NBC did the Charlie Foundation become founded. And I guess the ketogenic diet became a much more popular and prevalently used to help manage seizures. So thinking about the types or the 4 main types of the ketogenic diet that we'll be discussing today, many of you will have heard of the classical ketogenic diet, the modified Atkins diet, which was founded by the Johns Hopkins team, the medium chain triglyceride diet or MCT diet, and the low glycemic index or low GI diet. So looking first at the classical ketogenic diet, it's probably the one that most people will have heard of if they've heard of the ketogenic diet for epilepsy. This diet involves a strict and calculated diet that uses ketogenic ratios to produce ketones at a therapeutic range. So what we mean by a ratio here, so for example, a 4-to-1 ratio, the first number represents the grams of fat, and the second number represents the grams of carbohydrate and protein combined. And the reason why we originally restricted carbohydrate and protein is because at high protein intakes, amino acids can also go down a gluconeogenesis pathway and contribute to higher blood glucose levels and lower ketones. So in that sense, essentially, we're treating carbohydrate and protein as the same nutritional unit. So in terms of common ratios, you may have heard of a 4-to-1 or 3-to-1 ratio, but really the classical diet just describes, I guess, the macronutrient profile needed to produce ketones at a therapeutic range for an individual child. So for example, some children may respond really well and produce therapeutic ketones at a 2-to-1 ratio, whereas others might need a 4-to-1 or even higher ratio to produce ketones in a therapeutic range. It's quite an individualized calculation that is dependent on your child's age, weight, activity levels, as well as, I guess, their ketone metabolism and how efficiently they can produce ketones as well. So the classical diet is most commonly used in children with feeding tubes, and that's primarily because of the availability of metabolic formula that's usually subsidized by the government. Essentially, this formula allows for tight control of macronutrient profiles and the production of ketones within a certain therapeutic range. The classical diet can also be used in children who eat and drink orally, and again, that just involves each meal or snack calculated at a certain way so that it produces ketones consistently throughout the day. Now, for a classical ketogenic diet, different centers may do different things, but it's typically commenced as an inpatient admission, particularly for infants less than 12 months. And the reason why we do that for young babies is that we want to closely monitor our blood glucose and ketone levels just to reduce the risk of side effects and to see where our therapeutic range of ketones are. Now, the key considerations for a classical diet is because we're restricting protein, it's really important to monitor growth as well, because if we restrict too much protein, then it may result in poor growth outcomes. And I guess in terms of side effects, the most commonly reported ones would be our GI side effects. So things like nausea, vomiting, constipation can happen with a stricter classical ketogenic diet. Here we have some examples of classical ketogenic diet recipes produced for children as meals and snacks. So on the left-hand side, we have a vegetarian bake using a couple of key ingredients. So some low carbohydrate vegetables like mushrooms, cauliflower, as well as protein coming from eggs. And as you can see here, with the classical ratios, we can often calculate this with the support of some keto calculators, which can mean that foods are weighed out prescriptively, and this results in a certain ratio of carbohydrate, protein, and fat. So this particular recipe here would be designed at a 2-to-1 recipe. But again, these ingredients can all be adjusted in any way that you want to produce the ratio that's suitable for your child. On the right-hand side here, Jainu's provided an almond halwa recipe. So I guess in this case here, we're replacing wheat flour with our lower carbohydrate almond flour options. And again, with the keto calculators, we can work out exactly how much grams of the ingredients are and the corresponding macronutrient profile. And this particular recipe here results in a 1.5-to-1 ketogenic ratio. So moving on to the modified Atkins diet. So as we mentioned, the Kossoff team sort of founded this in the early 2000s. And I think this was really born from the need to be a bit less restrictive, particularly when it came to protein. And I guess, with our experience at Westmead is that with the modified Atkins diet, we can really facilitate and support many of these families to do the ketogenic diet, whilst the classical diet may not be as feasible for them. So with the modified Atkins diet, essentially we're aiming for 65 to 75% of total energy intake to come from fat. So these may be sources such as avocados, different oils, meats, or vegetarian sources of fats as well. The carbohydrate is generally restricted to 10 to 15 grams of carbohydrate per day. So really we're using our low carbohydrate fruits and vegetables, if any. And then again, the main distinction between the modified Atkins and classical is that we're not restricting protein. So we really encourage the use of protein to feel satiated with our meals and to also help children meet their growth outcomes as well. So I sort of touched on it just then, but I guess the foods that are included are our fats. So different fats would be oil, butter, margarine, cream, avocado, cream cheese, mayonnaise, as well as nuts and seeds. Often during our education, we'll talk about, we don't really like to use the term bad fat, but we'll use sort of better fats, I guess. So unsaturated fats would be our vegetable fats, whereas saturated fats would be more fats derived from animal products. In terms of protein, we can use meat, chicken, fish, and eggs. Vegetarian sources of protein can be cheese and tofu as well. And I guess with carbohydrates, we're really trying to use lower carbohydrate fruit and vegetables because this will allow greater portions with the meals and mean that children are satiated for longer. So in terms of foods that are avoided or limited, so obviously high carbohydrate foods such as cakes and lollies and soft drinks are avoided simply because they would not allow us to produce ketones. And then other higher carbohydrate staples such as bread, pasta, and rice are limited or avoided. And we're quite lucky in Australia, I guess, because with the increased popularity of the ketogenic diet commercially, I guess, for adults, we have a lot more commercial products available, such as low-carb breads and pastas. We'll often use cauliflower rice as an alternative, but that has increased, I guess, the variety of foods that children and their families can access. So here we have some examples of vegetarian modified Atkins recipes that we had created with for some of our patients at Westmead. So here we have a paneer jalfrezi, which uses paneer or halloumi as its main protein source, as well as low carbohydrate vegetables there as well. And then a keto dosa. So again, we're replacing our higher carbohydrate wheat flour with a lower carbohydrate almond flour alternative that allows them to continue to have these cultural foods within their diet. So here at Westmead, we actually use the modified Atkins diet as the preferred diet for children over the age of 2 years because we find that it allows children to produce ketones in a therapeutic range. Children generally have less side effects, as well as better compliance to the diet and tolerability of the diet as well. We also find we have better growth outcomes as there's no restriction of protein. Although we do find for some children, if they do eat large amounts of protein and that is affecting ketones, then there is scope for us to sort of look at that as well. And I guess with the modified Atkins diet, one of the big advantages is that it can be commenced as an outpatient and graded over at home in 1 week. And the process we do at Westmead is actually we'll do the education with the family. It usually takes about 2 hours. And then essentially over the course of 7 to 10 days, we'll wean onto the diet at home. So for example, they might start with 1 ketogenic meal a day for days 1 to 3. The 2 other meals and snacks would be regular meals. Days 4 to 6 would be 2 ketogenic meals, 1 regular meal. And finally, days 7 to 10 would be full ketogenic meals and snacks. And the benefit of this approach, I think, is that number one, we find that there are less side effects for children. So we find we get less sort of nausea, vomiting, food refusal, or I guess rapidly transitioning into ketosis. And secondly, for parents to be able to do this in the comfort of their own home, really they're weighing foods out, they're educating themselves around the foods and I guess what their children like to eat. And really, by only focusing on 1 meal every few days, we find that it's less overwhelming for families to learn the diet as well. And interestingly, in 2019, a big systematic review came out from Rezai et al. That found the modified Atkins diet is as effective as a classical ketogenic diet at reducing seizures. And the 2 key thresholds that we'll find in the literature is a greater than 50% reduction in seizures compared to baseline, as well as a greater than 90% reduction compared to baseline. So the medium chain triglyceride is another commonly used diet. I think the UK Matthew's friends tend to use a lot of the MCT diet as well. And the rationale, I guess, if we think about the types of fat that's in our food, it's predominantly long chain fatty acids. Whereas medium chain triglyceride refers to fats that have a carbon chain of 8 to 10 carbon atoms. And essentially the rationale is that MCT fats have a higher ketogenic potential. In other words, they are absorbed or oxidized more efficiently and will produce more ketones per gram compared to long chain fats. So this can often mean that children, if they ate the same amount of grams of fat, they would produce more ketones if you used more MCT fat in their diet. And essentially by using that high proportion of MCT, often it can mean that they can have slightly liberalized carbohydrate or protein targets, depending on the level of ketones that they're producing. Now, sources of MCT include MCT oil, coconut oil, as well as coconut milk and cream, as well as some of the commercial ketogenic supplements will have MCT oil in them as well. Now, some key considerations with the MCT diet is that high doses of MCT can cause gastrointestinal discomfort. So your main symptoms would be nausea, vomiting, loose stools. And so, at Westmead, we will often actually educate on the diet first. And if we find that ketones aren't where we would expect them to be at a certain macronutrient profile, then we might start to use some MCT to try and boost those ketones. And we'll often approach it in a dose-dependent manner. So we'll say, 1 teaspoon once a day, grading up through the meals. And we often find that children don't have as many side effects when we go slow. The other key consideration is that MCT oil has a low smoking point. And actually, about 5-10 years ago, we used to do metabolic cooking classes in our kitchen in the department. And we may or may not have set off some smoke alarms cooking with MCT oil. So it's important that when you're cooking, it's best not to use as the main cooking oil. Rather, you can add it to food at the end, or it can be added to different supplements as well to boost the fat intake. Now, looking at the literature, so it's quite interesting now that I guess the ketogenic diet is becoming more popular. We have different, I guess, sort of studies comparing the efficacy of different types of diet for different conditions. And I guess the big one that came out in 2009 from Elizabeth Neal and Helen Cross from Great Ormond Street, there was quite a large sample size, really. So they had 145 children with epilepsy, randomized to receive either the classical diet or the MCT diet. So relatively even groups, about 60 patients in each group. And they actually found that there were no differences in the number of patients who achieved a greater than 50% or greater than 90% reduction in seizures. They did find that blood and urine ketones were higher in the classical ketogenic diet group, which I think we would expect anyway, simply because it is a more restrictive diet. And they also found that there were no significant differences in tolerability, although the classical group did report increased tiredness and vomiting. And finally, I guess our last ketogenic diet or form of the diet is called the low GI diet or glycemic index. And I guess this was sort of developed in 2002 as an even less restrictive diet compared to the modified Atkins diet. And if we have a look at what GI is, so the glycemic index is a measure of how much a food raises blood glucose levels. So you can imagine here, if your blood glucose levels by time and you've eaten the food here, a higher GI food will spike your blood sugar level and cause the blood sugar levels to crash after a period of time, whereas a lower GI food will create a slow and sustained rise in our blood glucose levels. And essentially, the low GI diet encourages lower GI foods and a liberalized carbohydrate restriction. So they're often aiming for roughly 45 to 60 grams per day, which again, even compared to a modified Atkins diet, is about 3 times the amount that they're allowed, 3 to 4 times. And I guess with this carbohydrate restriction, the aim is not to produce ketones. Rather, it's to stabilize blood glucose levels and avoid large fluctuations in these levels. So as we mentioned, it's a medically monitored diet. And although I guess the term diet can seem a bit misleading as just a simple change in the way we eat foods, I think, when we explain the diet as a therapy to patients, I think we should be mindful that ketone bodies have effects in the body. And so it's important to make sure we're monitoring these just to reduce the risk of side effects as well. So obviously with any diet change that involves restriction, nutritional bloods are required at baseline, so pre-diet and on diet, to monitor for nutritional deficiencies. And I guess if we think about the types of foods that we might be restricting, so whole grains are really key in B vitamins, fiber, certain fruits and vegetables, lots of B vitamins and other vitamins and minerals in those foods as well. Dairy products might be restricted because of lactose. And dairy products tend to be quite high in calcium and vitamin D. So these are key nutrients at risk that we need to monitor and also supplement as well. So most children will be on a carbohydrate-free multivitamin just to make sure that they're meeting all of their nutritional needs. Now, to make sure that we're actually achieving ketones in the therapeutic range, we actually monitor blood or urine ketones to allow fine-tuning of the diet, as well as evaluating diet efficacy. So I guess if we're thinking about, most centers, I guess best practice guidelines will recommend a trial of the diet for 3 months, But really, it's important to make sure that, I guess, we're producing ketones in a therapeutic range to make sure that we're testing efficacy or seeing if the diet is actually effective for that condition in that child. It's important that we're doing food, ketone, and seizure diaries as well, particularly for children who respond to the diet, because this can mean, in order to fine tune the diet and make our ketones go up or down or whatever we're trying to achieve, the food is intricately tied to those levels. And then for children who do respond to the diet quite well, even a small amount of carbohydrate or a drop in ketones can result in seizures. So that's often why we will keep all three together, because they're very much correlated. And then, of course, with any diet, we're looking at growth monitoring, so regular weights and heights, just to make sure that we're meeting enough fat, particularly for young children. Once we're in ketosis, if we're not having enough fat, it is very easy to lose weight. And of course, for children, we want to make sure that they're growing along their centiles. So I'll just touch briefly, I guess, on the best practice guidelines. So this was from Kossoff and lots of different teams across the world. The most recent one from 2018 that lists several syndromes or conditions that have shown increased responsiveness or greater than the 50% mark or threshold that we use as a diet responder. And interestingly, CDKL5 isn't yet on this, I guess, table yet recognized. However, here at Westmead, we do find that we have had several patients with CDKL5 deficiency who have responded well to the diet. And so the neurologists will actually refer those patients a little bit earlier in their course of treatment rather than as a last resort. Now, there are some contraindications to the diet as well, and many of these disorders here are actually metabolic conditions of fatty acid oxidation disorders. So carnitine is a fat enzyme needed to convert fat into ketone bodies. So we can imagine if we don't have enough carnitine, then we won't be producing ketone bodies. And actually, carnitine is quite important, and some anti-epileptic medications can reduce carnitine. So some centers will actually routinely screen carnitine and replace that just to make sure they're optimizing ketone production. Now, in terms of other relative contraindications, we often find as well the biggest predictor for success on the diet, and I mean success in terms of reaching our 3-month mark. The therapeutic efficacy is usually based on the condition, but we find that the family's willingness to try the diet is a really big predictor. In fact, any referral that I receive where the neurologist tells me the family had asked about the diet, I often find it's really easy to work with those families because they really understand the importance of trialing it, I guess, and the level of monitoring that we need to see if the diet is effective. And so that's something that we really like to encourage the neurologist to ask is whether the families are willing to sort of look into what's required for this diet. Now, looking at CDKL5 specific studies, and I guess despite the fact that CDKL5 deficiency is a relatively rare disorder, we have had big international studies around the world and more recently in the last few years that have looked at the efficacy of the ketogenic diet for CDKL5 specifically. This study in particular came out in 2017 and used quite a large sample size of over 100 patients. So they had 204 individuals with CDKL5 deficiency, and they found in this retrospective audit that about half had tried the ketogenic diet with a median duration of about 17 months, and 88% experienced improvements in seizures on the diet. However, only about a third remained on the diet long term due to the waning efficacy over time. This more recent study from 2021 from Olson and the team at Harvard found that the age of initiating the diet is actually reducing. So 4.8 years is the mean age in previous studies, whereas more recently, I think it's reduced down to 1.9 years of age. And there is a higher trend of diet responsiveness in children who started the diet at less than 12 months, or 80% of children, compared to those who started over 1 year of age, roughly 40%. And I guess this study here looked at they found that about half the individuals with known clinically significant seizure response were ketogenic diet responders. So we're still using that greater than 50% reduction as our main threshold for diet efficacy. Now, this study here from Tsang et al. From 2022 was actually a big meta-analysis of the previous studies, and they actually included 12 studies involving 193 patients. And their criteria for inclusion in this study, at least in one outcome, which is definite diet responder. So this required the study to have included seizure diaries that provided an objective measure of reduction in seizures. And they found that the definite diet responder rate for CDKL5 was 18%, or roughly 1 in 5. And then the clinical responder rate was 50%. And so that wasn't necessarily based on seizure diaries, but may also just be reports of either reduced frequency or reduced severity, or other benefits associated with the diet that warranted continuation. Now, the most common GI symptoms were roughly vomiting, so 1/3 experienced vomiting, diarrhea or constipation as well. Great, so I guess wrapping it all up, in terms of our key points, the ketogenic diet is a promising therapy for individuals with CDKL5 deficiency disorder. And in the literature, the threshold for diet responsiveness is a greater than 50% reduction. However, some patients, ours included, also report anecdotally improvements in cognition, behavior, attention, and mood. Now, because it's a medically monitored diet, it must be implemented under an experienced team of neurologists, specialist dietitians, as well as nurse consultants. And that's to ensure that it's being monitored correctly and to reduce the risk of side effects. And I guess if we look at sort of the future research, we may be looking at exploring mechanisms of action between diet responders and non-responders. And I guess if we can understand the differences of why some children respond and some don't, it might allow us to better target potential patients in the future. Thank you.
Thank you so much, Erica. This was great insight, and there are so many questions that are already coming to my mind. So we'll take a quick pause, and we'll request Miss Dr. Nisha Venugopal. She's the Associate Director of IndoUSrare, to briefly talk about the IndoUSrare Summit. And that gives us all opportunities to think about any questions that we'll have for Ms. Erica, and then we can come back to you with those questions. So, Nisha, if you're online, please take it away.
Thank you, Jenu. Thank you, Erica. It was a wonderful presentation. And like Jenu said, all of us have a lot of questions and a lot of things to think about. We want to take a quick break here before we get the questions, like Jenu said, and want to add a little plug-in about our event that's coming in. We have a webinar in the similar format that's coming that Jenu will talk about. But from IndoUSrare, as Jenu said, our mission is to bring together different stakeholders from across different countries in the world so that we can accelerate access to therapies, existing as well as upcoming, for all rare disease patients globally. And our motto is to bridge nations so as to empower rare patients. And this summit, the Indo-US Bridging Rare Summit, that's planned for November 16th through 18th in New Delhi, India. It's a hybrid event, and this is a culmination of all of the different aspects that we work at IndoUSrare, our various programs. And we invite everyone to take a look at the agenda. It's turning out to be quite an interesting lineup of speakers led by FDA CBER Director, Dr. Peter Marks. As a regulatory keynote, we have Dr. David Pierce, who is going to be the keynote address, who's bringing together international rare diseases consortia work and similar. And there's a lot of opportunity to partner, attend, speak. And like I said, it's hybrid, so you can attend from wherever you are. So please check it out, and we look forward to having you all there. And check out our website as well, IndoUSrare.org, and like to hear from you. Ramya, I'll be putting the links in the chat window as we move forward. Jenu, over to you.
Thank you. Thanks, Nisha. Yes, and the next webinar that we'll be talking about is regarding dental hygiene and CDKL5 and other rare disorders. So please do register for that. So, Dr. Erika, there were a few questions in the chat. So let's get started with those. The first one that came in was regarding the timeline. So there was one of the slides that you presented with different diets, and does that mean like an older child who's been on the keto diet for a few years then can progress on the low glycemic index diet? And if you don't mind going back to that slide, just to
Yeah. Let me see if I can reach it. So that wasn't intended as a timeline. It was actually just a pictorial just to show the 4 types. I can pop it back up again. But it was actually really just all the way back. Just sort of a slide to demonstrate, I guess, what we'll be talking about through the course of the presentation. So what I'd say is that they're 4 quite distinctive diets, and that's not to say that the diet may not evolve from one to another. So, for example, I have had children previously start on the classical ketogenic diet that parents are interested in liberalizing to a modified Atkins diet, particularly after the 2-year mark, which in the literature, I think, I mean, it's a bit, there's not a lot of literature around sort of weaning or liberalization of the diet, but often as a first stage, families are willing to consider a slightly less restrictive form of the diet there. I would say the low glycemic index diet, it's quite interesting because I think it evolved from obviously children who couldn't comply even to the modified Atkins diet. I would say at Westmead, we don't tend to use it. I think I've used it once in maybe the last 5 years or so, mainly because actually we have quite a lot of success with the modified Atkins diet. And our population at Westmead is actually, we have a lot of South Asian, Southeast Asian, Middle Eastern families as well. So where we can, we do try and provide sort of culturally appropriate foods and alternatives for them there. So we find the classical diet is quite difficult to do and sort of maintain over time. And so we do find the modified Atkins is the one we find the most success with, at least for children over the age of 2 years. Under 2 years, I think classical is good because we have a lot of the formulas that will allow us to sort of calculate the ratios and be quite prescriptive and get the ketones in a range where we want them to be. Whereas modified Atkins, particularly as you get into adolescence, it often we find that liberalizing the protein helps a lot, at least in terms of planning the recipes. And I guess sort of longer term thinking about adolescents sort of trying to meet their protein requirements as well. Yeah.
Mhm. So on the similar on the modified Atkins diet, there was another question which was related to the protein. So the question is, unrestricted protein, does that mean that you don't weigh the protein, correct?
Yeah, good question. So we do weigh the food. So what we mean by unrestricted protein is when we teach a Mod Atkins, we often just get families to focus on 2 numbers. Rather than a classical, you're really juggling carbohydrate, fat, and protein to get the ratio where you want it to be. Now, when we educate, we generally give families 2 numbers, or one will be grams of fat. Sometimes we'll talk in what's called a fat exchange, which one fat exchange is 15 grams of fat. And essentially, we find that helps families to sort of understand or visualize the fat spread out over the day a little bit better. But essentially, even though the modified Atkins is unrestricted protein, we do weigh the food out because that's how we will make sure that carbohydrate and fat is being met. But what it means by with protein, it's often that your dietitian will keep an eye on the protein. In Australia, we use a lot of this app called Easy Diet Diary. I think in America, an equivalent would be like Calorie King or something like that sort of tracks the intake with an app. And we actually have software where families can send that diary directly to us, and we can actually see the macros quite easily rather than sort of manually inputting food diaries. So essentially what that means is we often just get families to focus on 2 numbers, the fat and the carbs, and the dietitian will look after the protein and just make sure that the needs are being met in that space.
Okay, so the protein we are not counting, but we are still looking at the
We
carbohydrate.
still look at it, yeah. And it's funny because I presented recently, so GLUT1 transporter deficiency is another metabolic disorder where the ketogenic diet is the gold standard. Essentially, there's a deficiency in the transporter that moves glucose across the blood-brain barrier, so they have to use ketones. And we've we're in the midst of publishing the first case of the using exogenous ketone supplements, so essentially ketone esters, ketone salts, in conjunction with the ketogenic diet to boost these levels up. Essentially, I had a 10-year-old boy who plays state basketball on the ketogenic diet, and he was having something like 130 or 150 grams of protein a day. And actually, when we sort of systematically started to reduce the protein without changing carbs, we boosted fat a little bit simply because you reduce protein, but his ketones actually came up quite impressively just by restricting protein at that intake. And so when you see that in action in real life, through the foods, through the levels, essentially we find with the modified Atkins, we will go unrestricted initially, but if we do find that the levels aren't where we'd expect them to be, there is scope for the dietitian to sort of say, okay, well, let's restrict protein a little bit, knowing that their minimum safe levels for growth are being met.
Thank you. Thank you for that. And on similar lines to this slide, the question is, which diet is more effective to reduce the seizures? So out of these four, what has been the most effective?
Yeah, so that's the $1 million question, I think. If we thought, I think the classical has always been the more traditional one, and we know it's the one that generally produces higher ketones. But if we look deep into the literature, there's not a lot of studies that actually support the link between higher ketones, meaning better control, better seizure control, as long as you've met like the threshold. And even then with the threshold, not all international centers will agree on what that threshold actually is, because some centers will do urine ketones, some will do blood. But yeah, I think for us, with that systematic review in 2019 that showed that the Mod Atkins diet was as effective as a classical diet, I think that really changed the way we thought about the ketogenic diet at Westmead, in the sense of, a lot of what we do with clinical practice has to be evidence-based. So if they've done a lot of studies and they've, compared, whether or not one's been more effective than the other, if they're equally as effective, our inclination is to go with the one that is more liberalized, less restrictive, has less side effects. And so I think that's why we do the modified Atkins. And I think, being able to start the diet at home has been really a game changer, with simply the number of referrals that we get. Beds are blocked everywhere around the world, without having to start it as an inpatient. I think that really makes a difference as well. So I'd say at the end of the day, with the choice of the diet, that really is a discussion to be had with you and your, ketogenic team. So your neurologist, your dietitian. A lot of centers should be able to accommodate for, they may not feel that the classical may be feasible. The modified Atkins might be a better bet, or if, I have had cases where children are so refractory that we're really at the stage before surgery. And then the doctors, modified Atkins wasn't feasible. So even low GI will try for a little bit and see. So I think it's important to be flexible with the approach that we take. And so I don't think there's really a one diet fits all approach for even CDKL5, I think. So, yeah.
Yeah, no, that's a great response. Like, each child is different individually. So whatever works for that child would be the $1 million answer for that child. Yeah.
Yeah.
The other next question is, my son is currently 11 months. Please share what supplements are beneficial for him on top of his keto diet ratio of 2:1.
Yeah. So I would say that it's best to discuss with your treating team around the supplements. Again, because different centers will do different things in terms of additional things that they like to add on top, or even with the frequency of nutritional bloods, different centers will do different things. I definitely find the sort of North American experience can be quite different to the UK Australian experience, even then as well. So I would definitely go back to your treating team. But I think in terms of supplements, you always want to think about what is the goal that you're achieving. So I guess if your child is producing really good ketones at a ratio of 2:1, beyond the multivitamin, if they are seizure free, or having that good control with seizures, I think any additional supplement on top, you really want to weigh up the benefits that you'd be getting from it with the addition of, I guess, another therapy, or another thing that they have to take during the day. Some of the children we get are still taking anti-epileptic medications and doing the diet. So I think we really try and simplify the treatment approach for them where possible. So we're not just adding things if we don't find them beneficial.
Yeah, no, that's a great point. And you did touch on carnitine a bit. And what I have heard is that, in vegetarian food sources, carnitine is not very high in quantities,
Mm.
so you usually need to supplement. So can you please just talk about that for a bit? That could
Yeah.
be some. Mhm.
So carnitine, you are correct. I guess with vegetarian diets, carnitine is primarily found naturally in meat products. So if you're a vegetarian, or as I mentioned, certain anti-epileptic medications like topiramate can actually reduce the carnitine levels as well. So again, with any supplementation, the medical team or the neurologist will guide us to the dosage of that as well. So that might depend on, I guess, the starting level, how low the carnitine was initially. I mean, as an enzyme, essentially there shouldn't really be too much of a risk of doing too much, if that makes sense. But just understand, I guess, with an enzyme, there's often an upper limit of the efficiency. So in other words, once you've reached the max utility of that enzyme, giving more does not mean higher ketones, but rather it's more if it's deficient at baseline and you're about to go on the ketogenic diet, it is best to supplement, at least to get the levels back up to normal, just so that we can give the body the best chance to produce ketones within the sort of fat intake that we're taking.
No, thank you for that. Yes, the last question that we have is regarding fluid intake, water intake levels to maintain while on these diets.
Yeah. So I guess with fluid intake, I mean, with any sort of daily food intake, there's often ways to calculate what that fluid might be based on weight, and dietitian can sort of help you with sort of the requirements based on age and weight. Now, I guess one of the risks of the ketogenic diet is kidney stones, and that's because of ketones are naturally acidic. And so, sort of passing ketones, as you would, when we measure urinary ketones, for some children, we'll do certain tests like urine calcium to creatinine ratio, etc., to look at the risk of that. Essentially, what that might mean is that we do recommend slightly higher levels of fluid intake, I'd say, with water, just to sort of keep things moving and flushing it out. But again, different levels might be sort of dependent on activity levels, the temperature outside. The thing to remember as well, and this most likely comes up when children become unwell, is that dehydration can contribute to high ketones. So we really, particularly when children are sort of vomiting or have gastro bugs, getting on top of hydration, and if that's not possible, then having IV fluids through like our medical hospitals coming to ED for IV fluids is often quite important, just to stop the adverse effects of too high ketones that we can sometimes have with dehydration.
Yes, thank you for that. Yeah, it's definitely super important, to avoid the side effects from long-term keto diet, as you mentioned, kidney stones and the impact on the kidney. Hydration is very important, so it's definitely important to discuss that with the dietitian and make sure that the child is getting those appropriate level of fluid each day. So the next question that's coming in is there's a child, it doesn't mention the ratio. It's morning keto powder milk, then lunch is followed with vegetables, dal, pulses, eggs, and 2 spoons of rice. Evening is fish, followed with dinner with vegetables with 1 spoon of rice. Uh, the keto levels are being maintained between 3 to 4 out of a scale of 5. And the parent is trying to ask if there is any room to add any fruit to this diet.
Yeah. So I think with any ratio for any child, it's best to talk to your treating team, just because I can't give advice for a patient that I don't know.
Mhm.
But essentially, I think with any, if the ketone levels are within the level that the team are happy with, then there may be scope to add fruit, and they may be able to guide, certain types of fruits. Like I think with any fruit, often I would say the berries are like your lowest carb option. So blueberries, strawberries, you get a bit more out of. Simply because we know like one medium banana is like 20% carb already. So picking your fruits will mean that they get more portion for the amount that they can eat. But I would probably say it's best to talk to your treating team, or if if the team is, or the dietitian is the one who's giving you the ratio, maybe it's a negotiation around of, okay, well, can I remove the carbohydrate from the rice and replace that with fruit? So, often teams can hopefully be a bit more flexible around that, or you as a family can sort of be flexible around that. Often it means that if the ketone levels are in the therapeutic range, potentially, but you'd probably have to check the ketones after you introduce the fruit, or alternatively, the carbohydrate might just need to be taken from somewhere else, if that's a food that you want to introduce.
Mm-hmm.
Yeah.
Oh, yep. Thank you for that. So we are at time, as well as I don't think there are any other questions. I just wanted to.
Quick question.
Yep. Actually,
Just one.
Shruti has a quick
Yeah.
question. So, how long is the keto diet sustainable? Is it practical to be on the diet for 10+ years?
Yeah. I'm trying to think of the longest a patient I've had have been on the diet, 16 years.
Okay.
But that was gastrostomy fed, so that was formula fed. He's now an adult, actually. We had him when he was a baby, and he's now an adult. But he has a very refractory form of epilepsy, and obviously with gastrostomy feeds, it gives you more easier control, I guess, over what is going in versus, say, if a child was on Mod Atkins. It is sustainable. I think it's definitely a discussion, or at least around weaning the diet. I like to call the discussion around liberalization of the diet. And I guess if we look at the evidence for a diet responder, there's evidence around sort of discussing a liberalization of diet at around 2 years, because there's some studies that have shown that, say, children who are seizure-free can actually maintain the benefits of being seizure-free, or having that reduction in seizures by slowly sort of liberalizing diet after that period. And so our approach might be, if you've got a really good diet responder, so some of the kids I have are seizure-free, or like 99% seizure-free, we might sort of slowly liberalize by adding sort of, if they're on Mod Atkins at 10 to 15 grams of carb a day, we might just increase by 5 grams every. It depends how comfortable the families are often. And then we sort of try and wean like that. And really you're trying to see the threshold if/when the seizures come back. If they don't, that's great. And the child, might be liberalized to 30 grams. And even that has made a huge difference to their life. So yeah, I think that's definitely a question, to be had, or discussion to be had with your treating team, about sort of how they would go about it, what you'd be monitoring, if you were to sort of liberalize after that.
Okay. Thank you. Yep. Any other questions? Yeah. Anybody have any other questions? So we have 2 minutes. You can ask, and definitely, this has been very helpful. Okay. So yeah, what happens in case of a child, especially in CDKL5, swallowing is difficulty,
Mm-hmm.
is always right. So
Yeah.
by swallowing is not great in my baby's case. He is having formula most of the time. Is he okay having pureed form once a day? Is that okay?
Yeah.
Yeah.
So I would say there's probably 2 professionals at least involved in that discussion. One is obviously the dietitian. The second is probably a speech pathologist who guides as to the safety of the swallow. And I guess the role of the dietitian, if a speech pathologist has told me that a child has dysphagia or swallowing impairment that requires thickened fluids or texture modified meals, my role is to sort of meet the needs of the ketogenic diet around those swallow parameters. So, for example, we might have children with feeding tubes, but can also feed a little bit orally. That might be the case. So what I would probably say for that scenario, if he's only having one puree food once a day, I think if that is what the speech pathologist or the treating clinician has recommended from a swallow safety perspective, I think that's fine. And really, you can still meet the requirements of the ketogenic diet with formulas or thickened formula with carbohydrate. So you'd be looking at carbohydrate-free thickeners, if available. It's perfectly fine to meet those needs because, we understand that different children, particularly ones with sort of neurodisabilities, there can be lots of other clinical symptoms that actually affect their overall nutrition as well. So you can definitely maintain the needs of the ketogenic diet with those parameters. But I wouldn't sort of go beyond that if a clinician has said, it's not safe to progress the swallow beyond, one puree meal a day.